set period.
And today we will be talking to you all about disc displacements. So our objectives are to understand spine disc displacement pathology, identify the causes, recognize clinical manifestations and functional limitations, evaluate appropriate tests and measures, differentiate from similar conditions, outline rehabilitation strategies for each phase, and discuss the outcomes and prognosis. What is disc displacement? A disc displacement is a change of position in the vertebral disc. It can occur in cervical, thoracic, or the lumbar regions. It's most common in the lumbar regions. What happens is it compresses the adjacent nerves / spinal cord, which results in pain, numbness, and weakness. Over here you have the types. You have a normal disc, then you have a bulging disc, a herniated disc, a degenerative disc, and a bending disc.
So the pathomechanics for disc displacements are age, injury, improper lifting, obesity, spinal conditions, and repetitive movements. And to go a little further, as far as age, it's usually due to loss of water content, which decreases the elasticity. And as far as injuries, you can get a disc displacement by being involved in a motor vehicular accident or falling. Improper lifting, you can lift heavy objects and have like improper body mechanics, and it also puts pressure on the disc. It can also be due to obesity, that also puts extra pressure on the disc, and due to spinal conditions such as scoliosis and kyphosis, and repetitive movements such as lifting, bending, and twisting. The clinical manifestations and functional limitations are localized pain, radiculopathy, weakness, numbness in extremities, and decreased range of motions. The functional limitations are difficulty standing, sitting long, impaired walking, bending, lifting, reduced grip strength and dexterity, and as well as difficulty completing daily tasks. The testing measures include the Sperling's test, which is when a healthcare provider lifts the patient's head and turns it to the side when applying gentle pressure. The distraction test, the upper limb tension test, and the bowstring test. The bowstring sign is used to evaluate for a lumbar disc herniations. And after a positive straight leg raise, slightly flex the knee and apply pressure to the tibial nerve in the patient's popliteal fossa. And they will have restricted movement with their range of motion. You'll assess their manual muscle testing. You'll probably find weakness with that. You'll also perform reflex tests to identify nerve involvement, as well as sensory tests to check for numbness and tingling. And you can perform, they can get imaging done, such as MRIs, to confirm disc displacements.
So all of those tests are for the differential diagnosis. And here are a couple examples of the things that you could find in replacement of a disc displacement. So they're kind of in order based on their likelihood. So starting off with the more rare cause would be a discal cyst, which is most likely a lumbar pain, and it causes radicular pain. So all of these conditions have some sort of growth or mechanical aspect to them that replicate the symptoms of a herniated disc or disc displacement. Second would be neuroma or schwannoma. So the Schwann cells on the peripheral nerve of your spine can develop these cancerous growths, which will protrude out into the nerve space and cause that compression as well. And then you have synovial cysts. As you know, there's plenty of synovial membranes inside of the spine itself, so those can have growths as well, causing those same radicular symptoms, which once again are found mostly in the lumbar spine. You have epidural abscess, which is very similar pain to a herniated disc. And then with more of a mechanical aspect on the last two, you have spinal stenosis, the narrowing of the spinal canal, which once again has those same radicular pain. And then unlike disc displacement, where the issue is the disc itself bulging out into the space with the nerve, spondylolisthesis involves a mechanical shift in the vertebrae where the actual vertebrae shifts on top of the disc itself. So that's what would cause that radiculopathy and back pain with that condition. But by correctly identifying the underlying pathology, make sure that the treatment that we use is targeted appropriately and help improve outcome for the patient. And then for the rehab overview, the stages that we've broken it down into are the maximum protection phase, so the first 1 to 2 weeks. Obviously, this is focused on pain management and reducing any inflammation. You don't want to progress the patient too fast in this stage, because the biggest thing that you want to do is avoid re-injury while they're at this very unstable state for their spine. But just plenty of rest and gentle range of motion exercises like pelvic tilts, or even just some like glute bridge exercises, just to get that most likely lumbar, but if not other areas of the spine moving. And then cryotherapy just for the pain management as well. Then for the moderate protection phase, so the 2 to 6 weeks after, and also these weak phases can depend entirely on how the injury is onset. If it's a sudden onset from an MVA or fall, it may present entirely differently than someone who has just degenerated over time due to overuse injuries. But in these 2 to 6 weeks, you want to kind of introduce their daily activities back to them, and core strengthening exercises. So that could be, something like yoga, as in the sense of like bird dog stretches, or depending on their fitness level, they could do something like planks or anything just to build that spinal stability muscles back up. And then for the last minimum protection phase, this is definitely dependent on how the injury is presented, because it can go from that 6 weeks up to 6 months, but anything past that would be considered the chronic stage. But you're focusing mainly on functional training for ADLs, and you're giving them activities that would kind of return them to work if they're not able to work yet. So this could be common for people, like if say they were a UPS worker, this would be something that over time they would be putting a lot of pressure on their spine, especially if they're not properly lifting packages or anything of that nature. So for the likely outcomes for your patient, you're searching for symptom relief with as conservative treatment as possible, because obviously if you progress them too fast, you don't want to cause any more pain or prolong the condition. In some cases, surgery may be required just because of how much pressure it's putting on the nerve itself. You wouldn't want to risk any long-term damage effects just because they're not receiving the level of treatment they need. And you're of course looking for functional improvement with their therapy, because over time, once you're doing that functional training, they should be able to return back to their normal ADLs, and all in all, a full recovery in around 6 to 12 months post-rehab.
For our overview, we have disc displacement is a change of the position of the vertebrae. This can be caused by age, injury, obesity, improper lifting, spinal conditions, etc. Your patients will most likely present with decreased range of motion, numbness, tingling, weakness, and or radiculopathy. Patients will have trouble doing activities such as standing up or sitting for long periods of time. An MRI is needed to confirm disc displacements, and your patient is expected to recover in 6 to 12 months. But as Seth said, everybody is different, so it could be longer, it could be shorter.
Any questions? All right, go back to your differential diagnosis content. Okay, so another condition that you want to add to this slide is sciatica. So take note of this. So sciatica, we know, is impingement or entrapment of the sciatic nerve. The sciatic nerve can be impinged or entrapped in several locations, but a hallmark location is the piriformis muscle. Okay, so now we have to assess the piriformis muscle. We have to listen to the patient's subjective report, especially if they have radicular symptoms. So if they have radicular symptoms, we have to do an assessment to rule out sciatica. Why? Because if they have a symptomatic bulging disc, and what I mean by symptomatic bulging disc is that the patient has radicular symptoms down the lower extremity. Now, sciatica can also present with radicular symptoms down the lower extremity. And you can see this on the National Physical Therapy exam. But what is going to differentiate sciatica from a bulging disc? So if the person truly has a symptomatic bulging disc, how are you going to differentiate um, lumbar radiculopathy, which is what it would be called if they have a symptomatic bulging disc. How would you distinguish that from sciatica?
Be based on the special test, what would relieve the symptom, whether it be a piriformis stress or like a distraction test of the vertebrae ball.
Okay, so good, Seth. So you can utilize special tests. You can utilize also repetitive movements. So McKenzie has repetitive movements that are utilized. So you can have the person to perform forward bending twice to see if that causes any ridiculous symptoms. Backwards bending to see if that causes a ridiculous symptom. Side bending, right and left, rotation right and left, doing all those twice to see if those cause any ridiculous symptoms. Now, typically, if any of those don't cause any ridiculous symptoms, then that would cue me to go look at the piriformis muscle and also hamstring muscles because of tight piriformis muscle and also tight hamstring muscles. So the sciatica can get entrapped and bogged down on as it trans the hamstring muscles as well. So most may overlook assessing hamstring extensibility. So you have to look at piriformis muscle, hamstring extensibility. You also have to look at hip range of motion, especially with internal rotation and external rotation. So now we're looking at repetitive movements. We may look at a special test, a quadrant test, having the patient to perform certain movements at the lumbar spine to see if those reproduce any signs and symptoms. So, but another one to add to this, another good one would be to add sciatica as one that we have to differentiate as well with bulging disc, and specifically a symptomatic bulging disc. Spinal stenosis is good. So spinal stenosis, now how are we going to differentiate spinal stenosis from lumbar radiculopathy? We get a patient and those can mimic each other. So how are we going to differentiate that?
You do like a neural tension test.
So you can use a neural tension test, but the best way to differentiate is repeated movements again, because the repeated movements are going to inform us if this person does have a symptomatic bulging disc. So for example, if the disc is bulging in a posterior lateral manner, and I don't have time to go into detail right now, but I'll go into that later. So if the disc bulges in a posterior lateral manner, most likely the person's gonna have pain, increased pain with forward bending. And their pain is gonna increase with forward bending, okay? And it's gonna likely cause ridiculous symptoms if it is a symptomatic bulging disc. Why am I saying symptomatic bulging disc?
So that's how it's presented. That's all we're gonna see is that they have radicular pain.
There you go. And there are asymptomatic bulging discs. People are walking around with bulging discs, but asymptomatic, having no problems from the bulging disc. So it's not causing any ridiculous symptoms, not causing any type of pain. So I have asymptomatic bulging disc. Anybody could, walking around, could have asymptomatic bulging disc. So, but if it's truly symptomatic, you're gonna be able to reproduce the ridiculous symptoms with movement. Okay, so that's the point that I wanna get to. So with forward bending, if it's a true posterior lateral bulging disc, the person's likely gonna have ridiculous symptoms with forward bending, repeated movements. Now say that you're not having the ridiculous symptoms with repeated movements, all right? Forward bending, specifically placing emphasis on forward bending because the posterior lateral bulging disc is the most common one that we typically see. If your patient doesn't have any ridiculous symptoms, again with forward bending, then you come back and assess backwards bending, and they have ridiculous symptoms with backwards bending, but not with forward bending. It could either be spinal stenosis, or it could be posterior medial bulging disc, which is gonna be painful. They're gonna have pain with backwards bending, because with backward bending, if they have a posterior lateral bulge, typically with backward bending, symptoms are relieved.
So if they have pain with backward bending, most likely spinal stenosis could be the cause, okay? And also, bulging disc can also contribute to spinal stenosis, all right? So, because you're gonna have decreased space of your foramina, which is your nerve exits. And so now you have to be cognitive of things that you can do to figure out what could be the likely cause of someone's ridiculous symptoms. Okay, so you have to put the pieces of the puzzle together, but we'll have more time for that when we get more time built into the courses. All right, so and typically also with sciatica, more so the pain is gonna start in the butt area. So that's another hallmark differentiated diagnosis, subjective report that your patient will report. Pain will typically start in the buttock versus the lumbar spine. So if it starts in the buttock area or anywhere in the gluteal fold and then going down, and that could be a hallmark report, subjective report that is getting your gears to turn and thinking maybe this could be sciatica.